Hi, everybody. This is Rob Dribbon, and I want to welcome you and thank you for joining today's PCPCC webinar called Primary Care Innovation in Medicare Advantage. During this webinar, we're going to hear from some experts about consumer-centered care delivery innovation in Medicare Advantage, and also some lessons learned from their work that could be applied to the broader healthcare system beyond Medicare Advantage. Before we get started, I want to just take a brief moment to share a preview of the next webinar. I know we're not done with this one yet, but I know we're probably going to go right at time today, so I want to make sure I get this one in. The next webinar is planned for next month, May 15th, from 3 p.m. to 4 p.m. Eastern Time, where we're going to be joined by three individuals, Dr. Anil Jain, who's the Vice President and Chief Health Information Officer from IBM Watson Health, Dr. Steve Waldron, who's the Vice President and Chief Medical Informatics Officer at the American Academy of Family Physicians, and we're also expecting to be joined by Lisa Barry, who is the lead for Health IT and Interoperability at the CMS Innovation Center, where she's working on AI-related initiatives, including the recent X Prize. So you'll see more about this and hear more about it over email. Be sure to check in with the PCPCC website in the coming days for more information. But again, it's May 15th, 3 p.m. to 4 p.m. Eastern Time. Just to level set for today, since we're all gathered around the PCPCC table, there's more than 60 organizations that are part of the executive membership at PCPCC who are committed to empowered, team-based primary care as the foundation of a high-value delivery system. Members of the PCPCC executive team will guide or help guide the PCPCC's future direction through participation like this, through webinars, policy calls, workshops, and other contact with the PCPCC staff. So please be sure, if you're interested in joining, to contact the PCPCC staff, and they'll give you a lot more real good information about what you could do to get started. One of the motivations that we've had for this webinar today has been PCPCC meetings with CMS. CMS, as you may know, they're considering developing a program that would identify and assign patients who need it to practices that provide more intensive services for higher payment. It's an idea which is really clearly pulling from some of the models that we're going to talk about today with our experts. And last quick plug here is that in November 4th and 5th, there's the PCPCC annual conference. So be sure to mark your calendars for that event in Washington, D.C. The list of participant speakers is being compiled as we speak, but I will share with you that Adam Bowler, who's the director of the CMS Innovation Center, is going to be keynoting at that event. So let me now turn to our panelists. We have three experts on the webinar today. I'll start with some introductions of each, or a little bit about each of them. Dr. Sachin Jain is currently CEO at CareMore Health, as well as a consulting professor of medicine at the Stanford University School of Medicine, and he's also a contributor at Forbes. He was previously CareMore's Chief Medical Officer and Chief Operations Officer, and before joining CareMore, Dr. Jain has worked as Chief Medical Information and Innovation Officer at Merck. He served as a physician at the Boston VA Boston Medical Center and faculty member at Harvard Medical School and Business School, both, and worked for the Obama administration as senior advisor to Don Berwick when Dr. Berwick led the CMS. Next panelist is Dr. Gaurov Dayal. Dr. Dayal is president of New Markets and the chief growth officer at ChenMed. Prior to joining ChenMed, Gaurov was a senior vice president at Lumeris, a comprehensive population health solution provider. Dr. Dayal also served as President, Interim CEO, and Senior VP within the SSM healthcare system, which is the nation's first healthcare system to receive the U.S. Department of Commerce Malcolm Baldrige National Quality Award. And finally, our third panelist is Dr. Hwang. She's the Director of the Center for Consumer Engagement and Health Innovation at Community Catalyst. She continues to engage in health policy education as a visiting fellow in the Department of Healthcare Policy at Harvard Medical School. Her dual roles as physician and health policy expert give Dr. Hwang a unique leadership perspective, and prior to joining Community Catalyst, Dr. Hwang served as Director of Healthcare Policy and Strategy for the Massachusetts Executive Office of Health and Human Services, and also as a Senior Health Policy Advisor to the Massachusetts Health Connector. So I'm sure you'll agree we have a top-notch panel of experts for today's discussion. We're going to engage in a discussion-type format for our panelists. So it's not just going to be about them presenting to us. It's going to be about a discussion around some key questions that we've compiled, and also questions that you, as participants, will be asking us on the line. We'll encourage you to type any questions that you have in the question box on the webinar on your computer, and we'll try to incorporate as many of those questions as we can into the conversation as it moves along. I'll try to do my best, knowing that we have a limited time here with the next 50 minutes and counting. So we want to make sure we get as much in as we possibly can for all of you today. So we're going to start with some short introductions from each one of our panelists. I'm going to start with Dr. Hwang, then to Dr. Jain, and then Dr. Dayal. About 4 minutes each for each of their opening comments, and after their comments, and you'll see they'll walk through some slides, so be sure to check your screens as we go along here, and then we'll move into some Q&A. So Dr. Hwang, over to you.
Okay, great. Thanks so much, Rob, for that introduction. I'm delighted to be here today. As Rob mentioned, I run the Center for Consumer Engagement Health Innovation. This is part of Community Catalyst, which is a not-for-profit consumer health advocacy organization. Next slide. This organization focuses on building the strong voice of consumers in health policy and practice change. And we do this in a number of ways by supporting consumer advocacy and outreach, working directly with healthcare organizations to improve their consumer engagement, engaging with policymakers, and conducting research related to policy and practice. We have a strong focus on people with the most complex health and social needs. And I'm particularly thrilled to be talking about primary care and the ways in which primary care can and should improve, in part because I'm a primary care physician, and my practice is exclusively working with people with very significant needs. And it's also the same population that I engage with in my policy work. And we simply know that this population's needs are not met in a traditional primary care system. You know, the people that I see in my practice and that I work with have a large number of chronic conditions. Many of them have functional and behavioral health needs. And a 15-minute office visit when you can't even get through a med list simply is not effective. Next slide. I know I'm speaking to the choir here, but you know, primary care is such an important issue for consumers. I just wanted to focus a little bit on that graphic that I tucked in the bottom right-hand corner of your screen. This is from a series of papers, the first published in 1961 and the next one published in 2001, both in the New England Journal of Medicine, which looked at an average US-based population and where that population intersected with the healthcare system over the course of a given month. And what was, sorry, a given year. And what was really, what was very surprising was just how consistent the patterns were. And basically, when you look at where people receive their care, that bottom right corner, just 9 people out of 1,000 accessed hospital-based care. And the rest of the people either were well and didn't have any interaction with the healthcare system, or were in an outpatient primary care setting. So, you know, much of healthcare policy really focuses on that tiny corner in the bottom right, where people actually receive their care is out in the primary care system. And so when people have frustrations with the primary care system, it reflects in their views of healthcare as a whole. And when the primary care system, you know, does well, they tend to have, you know, certainly better outcomes throughout. So if you go to the next slide, our organization did put together some policy recommendations about how the primary care system could better serve consumers. And a lot of the recommendations, I think, are consistent with some of the things you'll be hearing about later today. They focus on really what we would consider the 3 pillars that are necessary for better health. That's strong coverage and access, so making sure people can even access the primary care system. Improving the quality of services that consumers receive. And then the third broad area is around how do we start to incorporate some of the upstream factors, the social factors that we know really are determinative of people's health, and how can the healthcare system start to meet those. So next slide. Just included here just a few resources of some of the work that we've done that relate to primary care that might be of interest, and I'm really looking forward to the discussion this afternoon.
Great. Well, thanks, Dr. Hwang, for that intro and comments. We're going to turn it now to Dr. Jain.
Thank you so much, Rob. And it's great to be on this panel. Rob and I were colleagues at Merck. Ann and I trained together, and Gaurov and I have known each other for a while. I have a lot of respect for everyone on the call, so really appreciate it, and thanks for tuning in. My brief remarks are entitled Radical Healthcare, and it's kind of a tongue-in-cheek use of the word radical, because a lot of what we believe at CareMore is that what we need more of in healthcare delivery in the United States right now, really more than anything, is common sense. When you think about the things that are going to change healthcare the most, I personally don't believe it's going to be the proliferation of apps, blockchain, AI, and all the other solutions providers who likely spam you all every single day. I think it's going to be going back to the basics and just really taking care of people and thinking about what they need and actually addressing those needs. And that's a big part of who CareMore is and what we're really about. We are focused on really the a differentiated care model for the top 5% of patients that ultimately account for 50% of the cost. And I think one of our biggest problems in U.S. healthcare is that we have this view of the median patient, and the system treats everyone equally. It's this kind of failed American egalitarian ideal of healthcare delivery. And we believe that the top 5% of patients, folks with a high burden of chronic disease, people with complex and complex illnesses, really need a different approach. Next slide, please. It really requires a very different view of the consumer. I believe one of the biggest challenges we have in healthcare is this kind of consumerist view that we need to just put power in the hands of patients and then all the right things are going to happen. I personally reject that view. I think most people who are real patients, people who have a high degree of complex illness, actually just need a healthcare system that's going to proactively take care of them. So, I believe that the healthcare system should anticipate and deliver on people's needs. Sick people should not have to shop for the care that they need, contrary to, I think, the consumerist dystopian view that I think we have at broad scale right now, and that fundamentally people should not pay out of pocket for things that they need. I think the best example of that is copays for insulin, which many health plans offer. It doesn't make sense. It's a lot more expensive to take care of a patient when they get admitted to the hospital with hyperglycemia because they can't afford their insulin than it is to just give them their insulin at zero copay. So, the types of patients we take care of are diabetics, people with multiple comorbidities, people at or slightly above the poverty line, and the average age of our patients is 74. And again, I think this demands that we look at our patients differently and design a system differently. Next slide, please. CareMore has a comprehensive model that really focuses on a traditional primary and specialty care network, but then wrapping around that traditional network, intensive chronic disease management services, extensivists who are hospitalists who will follow the patients from the hospital to the SNF and then continue to manage their post-discharge care, an intensive care management and community engagement infrastructure, and then a real focus, I think, on continuity. I think we believe that continuity of care across all sites of care is really, really important for the sickest patients. And we integrate comprehensive primary care as well as behavioral health care, which ends up being a very significant piece of how you take care of patients with a high burden of chronic disease. Next slide, please. And we also have, I think, an underlying focus on social determinants of health that, this is, CareMore is a 25-year-old organization. We were doing these things long before the industry was using the term social determinants of health, but we were the first health plan to partner with Lyft to provide transportation, but we've provided transportation for most of our 25-year history because we believe that is a real barrier for patients to get access to their care. We have built the first, an industry-first program to address loneliness that we call our Togetherness program. We believe that loneliness is a treatable condition. We're now trying to take our care model virtual, and we selectively integrate technology where it addresses the pain point of clinicians. We believe that fourth leg of the quadruple aim is really, really important. We aspire to be a system that people love to practice in, and that's a big area of focus for us. So very excited to talk more about all of this in the Q&A, but I'll now hand it over to Gaurov, who will tell you a little bit about ChenMed. Thank you.
Thanks, Sachin, and thanks, Chris, Rob, Sachin, and Ann for putting together such a great panel. I'm excited to be here. I think PCPCC does great work, and we're really pleased to be part of this. So just really briefly about ChenMed, we are a primary care practice that focuses on low to moderate income seniors. We operate under 3 different brands: Chen Senior Medical Center in Florida, Gen Care in 4 states, and then Dedicated Senior Medical Center in an additional 2 states. We have been around for about 29 years, initially started in Florida and gradually expanded outwards. To Sachin's points earlier, I think we're very like-minded in our approach that the challenge in the U.S. healthcare system isn't one about technology and innovation around blockchain, to use one of Sachin's examples. It's really around access, treating people with respect, and doing common sense medical interventions that have been proven to work and honestly are not terribly expensive. There was a recent article that came out by Dr. Robert Pearl a few days ago that talked about the fact that ROI on primary care is so much higher than in specialty care, the return on investment. However, because of the specialty-centric nature of the U.S. healthcare system, we continue to push, a boulder up a hill, trying to do more and more, but still getting less and less. So we take the same view as CareMore does around this, that there's a lot that we can do if we just focus on the basics. So our mission is that to be America's leading primary care provider, transforming care of the neediest populations. When you look at our model, it's really around honoring seniors with affordable VIP care that delivers better health. In our worldview, both VIP care and affordability are critical factors because there's a high linkage between them. So what we like to say is that, for a lot of concierge practices charging $2,000 a year, $3,000 a year, and to give high quality care, that's a no-brainer. Of course they can afford to do that. What we are attempting to do is to provide the same level of care within the confines of the Medicare Advantage program so that it's free for seniors and that they get the same level of care and outcomes that a wealthy person in the suburbs of any major city in this country would get. So we operate, this summer we'll open our 64th clinic in our 8th state. We take full global risk for Medicare Advantage and dual eligibles, and by full global risk, it's basically for I know this is a specialized audience, Part A, Part B, Part D, and stop loss, everything. As I mentioned earlier, our goal is to really provide a concierge level solution to all of our seniors. Next slide, please. We really focus on high touch care, and just some attributes of that. Our physician panels run around 450 per doctor. I know if there's any primary care physicians on the call, they probably think I'm missing a 0 on there. In fact, our company is running closer to 350 at the moment. We really think that high level of concentration is critical for doctors to perform well on patients such as ours, who on average are 74 years old and have 5 chronic conditions. Our standard clinic, just to put in perspective, is the size of a Walgreens or a CVS, each with about 6 doctors and a care team that is geared towards their patients. We also have on-site specialists. Typically, cardiology is always embedded within our model. Many other, the clinical model, the model is not just clinical, there's a lot of other things around care coordination, transitional care, case management, and what we call care promoters that really are a one-stop shop for our patients. In addition, we have several things on site. So we have on-site labs, on-site x-ray, and on-site pharmacy as well, which is critical for us because what we do is we mimic the Part D benefit for Medicare Advantage members with our pharmacy offering so that we can give patients the drugs they need for low to minimal cost on site. In addition, we also have a lot of on-site programs. Our clinics tend to be in underserved neighborhoods. So we have a lot of other offerings that we have in our clinics around acupuncture, Tai Chi, social events, silver sneakers, so that patients remain engaged with us. On average, we see our patients about once a month. We also provide door-to-door transportation for those patients who request it. Next slide, please. This is just this is published data on the right side from American Journal of Managed Care. We do think that by providing this level of service, we are able to drive significant better outcomes, both from a utilization, patient satisfaction, as well as a cost perspective. So we are able to see about half reduction, 50% reduction in hospitalizations, about a third reduction in emergency visits, which of course leads to lower cost. At the same time, we're very proud of the fact that preventive care metrics we do very well in from a STARS perspective as well as from a medication use perspective. At the same time, we focus a lot on the experience. The founder of the Ritz-Carlton is on our board, a gentleman by the name of Horst Schultz. We really think that, you know, to drive these results really requires high engagement, and high engagement really requires a very high level of service to these patients. So, so we really focus on that and really try to drive 80+% net promoter scores. Next slide. That's it.
Great. Well, thanks to all three of you for providing an excellent overview and incorporating some of your own perspectives. We're going to turn it to a question and answer session now for really the remaining time. So again, please feel free to send in some questions. I'm monitoring that as we speak, and just to give you all a sense, we have almost 400 people on the webinar at this point, and a few of the questions are actually relating to the questions that you'll see posed. So I'll try to incorporate them where we might not be covering it in these questions. First question I'd like to pose to Anne, to Dr. Hwang. What are some of the opportunities for more flexible payment models to result in more consumer, patient, and family-centered care? Dr. Hwang?
Great, thanks for that question, Rob. So, you know, I think basically what we're trying to do is fundamentally reorient the way that care is provided, you know, to shift from a system where as a provider, I think what are the services that I can provide to what is it that a patient needs? And if you think about it in a very concrete example, you know, if someone comes into my office and has foot pain, there's a whole laundry list of things that have CPT codes that I'm allowed to order, you know, ranging from x-rays to, you know, specialty referrals, et cetera. But if what the person actually needs is a pair of shoes, you know, that's comfortable and supportive and that fit, you know, that's not covered under traditional medical systems. So in the best of all worlds, what we're trying to do is to restore a healthcare system that is focused on, you know, not CPT codes, but what is it that a person needs and how can I then meet those needs? So that's really the promise. In flexible payment, the hope is that it serves as both a push and pull mechanism. Say push because it should provide the funding mechanism to provide more flexibility to deliver the services that are needed. And then on the pull side, if you can set the incentives correctly, you know, the hope is that you can also pull you know, providers to reorient towards the goals and the needs of the patient.
Thanks, Anne. Helpful. So your focus in that, in response to that question, is directly related to the consumer, the patient, and the family. We did get a question from somebody on the webinar about, and which I think might relate more to Sachin and Gaurav. How do you partner with private payers to ensure that this model is financially sustainable? So Gaurav or Sachin, you want to take that one?
Yeah, this is Gaurov. I can take maybe a first pass at it. So we at ChenMed, we operate under the Medicare Advantage program only. So just by definition, and for those of you on the call who don't know the mechanisms of that, basically Medicare Advantage is capitated Medicare that is privately administered. So many of the large national healthcare insurers, health insurers, as well as regional blues administer that. And what we do is we take full capitation payments from that. Frankly, the only way for us to provide the level of services and the outcomes we're providing is because of the fact that there is a capitated payment that enables us to make the investments in clinics, doctors, low panel sizes to drive results. We think it's a very good return on investment, but in a fee-for-service model, it would be impossible to drive these kind of results because our average PCP would have to be seeing 3,000 patients or 2,500 patients and seeing them for like 10 minutes a piece, maybe 5 minutes, for this to be even sustainable. And there's no way we'd be able to drive the results. So it's very critical for the financing mechanism to have some upfront payment that supports investment in preventive disease management that currently is not paid for very well. And second, to take a long-term view, right? The ROI, the return on investment on these payments are not going to be garnered this month or possibly even this year. It may take 4 to 5 years. So it is a long game, and it requires financial resources upfront to make the outcomes happen.
Great, thanks,
Gaurav. I think that was a great summary, Gaurav. I appreciate it. One thing I'll just say is, capitation has historically been has been a controversial word within our industry. I think really stemming from some of the managed care backlash in the early 90s. But I think organizations like CareMore and ChenMed tend to view capitation as freedom, not risk. And I think that there's an important distinction there. It's the freedom to do the right thing for the patient. It's the freedom to invest in primary care. It's the freedom to invest in interventions around social determinants of health. It's in the freedom to do the things that we know are going to keep the patients out of the hospital. I think one of our industry's biggest challenges is that we don't have payment models that actually support the translation of best evidence into practice. And one of the amazing things about transitioning from, kind of working in some of, the nation's kind of preeminent, fee-for-service healthcare delivery systems is no matter how hard they try, they can't do some of the things that we do at a CareMore or a ChenMed because we get the full Medicare dollar. We've, over the past couple of years, actually transitioned to do this on the Medicaid side as well. It really enables you, again, to implement this vision of radical common sense. If your patient, can't take insulin, can you buy them, or because they don't have a refrigerator at their home, do you buy them a refrigerator? Those are the types of things that we think about because we have that full responsibility for the full Medicare dollar.
This is Anne, and I'll just add, I just wanted to round things out. I think there are some initiatives on the private side. We see them with some employers. I think Boeing, for example, has contracted with Iora Health, and there are a few other examples like that. So there are some similar initiatives on the private side. I think, certainly with Medicare being such a large payer, there's an opportunity to do this in an aligned way at a much bigger scale.
Great. Thanks to all three of you. Here's a specific question for you that comes in from somebody on the webinar. How are clinical pharmacists and clinical pharmacy services embedded into your practice models? So Sachin and Gaurav?
Yeah, I'm happy to take that question on. CareMore has, I think I call pharmacists like the secret weapon of American healthcare. They fly under the radar. People don't really talk about them very much, but at the end of the day, I think these are highly skilled, underutilized professionals who can do so much more for patients than I think we're really enabling them to do. The other thing I'll just say parenthetically that I think is important is that they're highly collaborative. I frequently joke that many people can name doctors and nurses and who have upset them historically, but very few people can kind of identify a single pharmacist. I think it's part of their training. We have them deployed at CareMore to do things like medication reconciliation, addressing polypharmacy in a senior population, really, targeted focus on adherence, both from a STARS measure, regulatory perspective, but also just from a patient level, engaging with the individual to understand their barriers to care. We have pharmacists who are involved in, making formulary decisions because, in an environment of rising drug costs, being able to look at all the different therapeutic options and identifying kind of select, medicines where there's opportunities to hold outcomes stable but lower costs is a huge opportunity. We've also used pharmacists to execute large-scale medication shifts. We recently switched all of our patients from analog insulins to human insulins because of the crisis that we have in our country around insulin costs, and we were able to do that without using primarily pharmacists without lowering healthcare costs. So this is something we're very passionate about. We think that when we talk about primary care shortages in the country, I really do believe that pharmacists are going to be a big part of the solution that that we haven't really explored at the depth that we should, nationally.
I fully agree with Sachin around, and I want to add to the importance of pharmacists and the role they can play. I do want to just maybe further expound on that fact from just an ease of access to medications. When I was practicing medicine, I don't think I ever thought about, what the cost of a drug is and how a patient's ever going to get it filled. And I don't think many doctors actually have the luxury to think about that, even if they wanted to. So if you think about, I think I read a statistic that maybe 40% of prescriptions written in this country are never even filled. And think about the significant steps that it takes. A doctor writes a prescription, gives it to a frail, like 85-year-old or who has poor transportation, who may or may not be able to get to the pharmacy. Once they get to the pharmacy, it may or may not be within their benefit design, and they may or may not have enough money to cover the copay. And even if they get the medication, they may or may not take it. Compliance is obviously a big issue. So when you start adding all of those holes in the Swiss cheese, there's an exponential effect on our ability or inability to drive patient behavior in taking medications. In our model at ChenMed, and many of the direct primary care models, what we are doing is we're giving the medication into the patient's hand. Are the doctors doing that themselves with the assistance of the pharmacy or the pharmacy tech, saying, in the same case, if that patient needs a drug for cholesterol, we make sure right there that it's within their formulary. We fill that drug, we give it in their hand, say, I'll see you back in 30 days. Please come back and bring this bottle back with you, right? So just by virtue of removing significant logistical and financial barriers, compliance goes up, which significantly improves outcomes in the typical 4 or 5 diseases that we're all dealing with over and over. It's diabetes, hypertension, hypercholesterolemia, depression. Those things are really very easy to impact if you have the ability to impact them.
Yeah. So building along those lines, Gaurav, your companies in particular, ChenMed and CareMore, you've been doing a lot of impressive things to address areas like specialized care for high-needs seniors. Sachin mentioned earlier around senior loneliness. If you could speak a bit more to the comprehensive primary care opportunities that exist under Medicare Advantage, especially in light of some expansion of services under Medicare Advantage as well. So I'd love to hear more about that.
Yeah, so I think that there's a lot of opportunity to provide similar levels of care, and in fact, I would think that everybody should deserve good primary care, regardless of whether they're a Medicare recipient, Medicaid, uninsured, or have commercial insurance. I think the challenges, at least in my mind, are twofold. At the very least, one is a policy issue, right? So what is the aggregation methodology even to make sure that we can deliver these kind of services to commercial populations? Anne mentioned Boeing, and yeah, there's a few companies that may have invested in direct primary care, but there's still exceptions rather than rules. The other issue that comes up a lot is sustainability of this, and we're seeing this, even in the federal government with the ACO model, right? People have made investments in these programs, and I'm not placing blame, good or bad, but the policy, the federal policies do continue to change. So a lot of folks find themselves having made investments, but now not having anything to show for that. On the flip side, If you talk to CMS, they'll say, well, this is sort of a upside only gain and no downside risk, and it's not really symmetrical. And I know there's changes coming in place, but I think the takeaway is that to make investments of this level, you have to be confident that 4, 5, 6 years from now, there will still be a program around to show results from. And I think the other thing is just the transient nature of people. So for example, in a direct primary care model, if it's employee sponsored, some of those people will no longer be employees 2 years from now. In Medicaid, you know, Sachin can speak more to this because they take Medicaid risk as well. Medicaid is a high churn population, so investments required that are made in Medicaid members by either a plan or a provider group such as ours may not yield results in the next year, and by the time they do, the patient may be off Medicaid rolls. So I think those are the structural challenges, and it really shows that, you know, running these parallel models between fee-for-service and risk/capitation is a challenge, and until there's sort of an overarching one delivery method in this country, I think we're going to continue to struggle between how to get people into these models.
Yeah, I agree with everything Gaurav. Predictably, I agree with everything Gaurav said. I think one of the main opportunities is to implement this vision that I think you know, has been separately described by Jim Maltz, who's a technology entrepreneur, as ubiquity, or by Kevin Volpe, who's an academic at the University of Pennsylvania, as automated hovering. You know, we need to kind of get outside of this view that the main kind of point of access to the healthcare system is, you know, the clinic or the hospital, and get to the view that, you know, the reality that most people probably spend, you know, most people with chronic illness probably spend 20 to 30 minutes with clinicians during a year, spread out over 3 or 4 visits, and get to the view, I think, that, you know, most patients spend most of their lives, most people rather spend most of their lives outside of healthcare settings. And, you know, it's 2019. I think we all need to wake up and realize that technology is going to only work if it allows us to have a clear sense of what's happening to patients outside of the clinic, but then we also need to have payment models like the ones that we're operating on under that are going to enable us to, you know, be rewarded for the good work that we do outside of office visits to actually take care of patients. And so the relationship between the patient and the healthcare system needs to become one that is more continuous or ubiquitous, or, you know, some notion of this idea of automated hovering, so that there is a constant connection present, one that allows us to intervene, you know, when patients are going off course, or when their medicines, you know, stop being effective, or, you know, whatever may be driving negative outcomes with them. So, you know, I'm quite optimistic that I think we're at a place where there's a collision of technology and payment models that's going to begin to enable new delivery models. But I think that's the opportunity. That's what everyone on this call, I think, needs to be focused on for the next 5 to 10 years.
Great point. And I have a question for you that's coming in from the somebody on the webinar, and it's regarding insights that you may have learned from patients. Basically, what this individual is asking: how do patients want to interact with the care delivery system related to these models and maybe even beyond? So basically, they're asking about, you know, what do patients think and what do patients want? So, Anne, what are you hearing? What do you know?
Yeah, so I mean, I think, first of all, I don't think there's a single answer to that question. You know, I think there is some, you know, different people have different goals and preferences and needs. So I think what we're looking for in the system is a system that is flexible and that can accommodate the needs. You know, I think in terms of what we hear specifically around primary care, and again, we work with a very specific segment of the population, particularly people who are served by public programs, have very, very complex health needs, and oftentimes have functional limitations. Is that a primary care system where you have to go to an office, you wait for half an hour and you're seen for 5 minutes, is woefully insufficient for tackling the what people need from in order to stay healthy. You know, a lot of things we hear about are in the social determinants of health domain, and then, you know, then it's making sure that there is a healthcare system that listens, that is trusted, and that that is accessible when people need to be seen. So I think there's some variability, but those are the broad, I guess, values, I would say, in a system that is more consumer responsive.
Thanks,
the other, I would also just say, I will also say that as we think about sort of the primary care system of the future, I think you will see more segmentation. There are probably some people who are young, who are healthy. I think about probably some of like the people we interact with in our, as students or whatever, who don't necessarily want to, go in and spend an hour talking with a healthcare provider. And there are sort of new technologies that are coming out that provide different levels of interaction, that again, depending on people's needs, may be what they're looking for. So it's certainly not a one size fits all scenario.
If only it was. Great point. So we mentioned before, and thanks, Anne, we mentioned before about capitation programs. Sachin and Gaurov were mentioning. One question that came in from the webinar, CAP programs usually don't see patients as often per month to support a positive ROI. How are you sustaining financially with the number of visits that would be necessary to be sustainable in that type of model?
This is Gaurav. I'll take I think I understand the question, but I think a few clarifications. At least in ChenMed's case, and I know for many of CareMore's patients, we are a full capitation model. So we're not taking capitation at a monthly, X $100 a month. We're taking full actuarial risk on these patients. Now, just broadly speaking, the payments for a typical Medicare Advantage patient can be often north of $10,000 PMPY per member per year. I mean, we're getting a subcomponent of that payment. Now, it cuts both ways because by taking full risk, we also have unlimited downside as well, meaning if a patient's running a $2-3 million medical loss, that also comes from our pocket. So I think maybe that's a good clarification point that in models such as ours, we are taking full actuarial risk, not taking quote unquote just a cap payment. Second, which also I think is an important fact, at least as it relates to Medicare Advantage, this is a risk adjusted premium. So unlike a typical capitation model where you're getting a fixed PMPM per member, Medicare Advantage does have risk adjustment, which does then pay you higher for sicker patients, which is fair because sicker patients, cost more, but also take a lot more time. And finally, in our case at least, because of the structure of the payment methodology and our ability to invest in the clinics, we do see our patients a lot more than a typical physician group does. On average, we're seeing our patients about once a month, even if they're healthy, with the intent that we keep them healthy by seeing them frequently.
Thanks, Gaurav. All right, so in the context of these new innovative models, particularly focused on primary care, what are some of the barriers to the scaling and spreading of these models? Think about it this way: why can't I find a ChenMed or CareMore on every corner, so to speak? So what are some of the challenges that you all feel are getting in the way of that type of expansion?
Yeah, I mean, I'm happy to take that one on. I would say that there's, it fits into probably four main categories, Rob. One is adequate risk adjustment. So, organizations need to be, rewarded or paid adequately to take care of the absolute sickest of the sick and provide them with a differentiated care model. And, risk adjustment is an imperfect science. And so, I think we are still kind of evolving towards a system that really pays people for what the work that they're doing, but I don't think we're fully there yet. I think there's a lot of variability in Medicare-based payment rates that are, vary across geography, but those two are imperfect. They are benchmarked to, local costs, but in some markets, it's way more expensive to deliver this type of model of care than in others. I think that's a big problem. I think the third is around member acquisition. I think very few people fully recognize that Medicare Advantage is a retail sale. It's, kind of, we grow kind of one member at a time. And so when you are growing one member at a time, you can't start in a market and cover all your costs right away necessarily. And so it requires, I think, pretty significant investment, which oftentimes has a very long payback horizon. So, I always say it's a miracle when someone joins a Medicare Advantage plan with CareMore because, they're trusting us to, deliver better health care than just about anyone else. So it's a very significant and intensive sale. And then the last part is really, I think, around the spread of any specific model is I think, really physician readiness for, clinician readiness. I don't like the word provider. I think it's not a good word. But, I think, physicians, nurse practitioners, APC, this is a very different model of care. You're not paid on a per widget, per visit basis. You're paid based on health outcomes, and that's not necessarily how we're trained. And, and it's certainly not how you're paid in most clinical practice settings. And so making the switch requires a deliberate transition from in mindsets from a fee-for-service world to a full risk world where you are really, worried about whether your patient gets admitted to the hospital or not, because it hits, your bottom line. And so, we're investing very heavily in training capacity. And I think one of the things Gaurov and Rishika at IORA and some other folks in the space and I, we were at a conference recently, we were talking about, honestly, potentially getting together, an annual summit or a conference where, we did talk through some of these issues and worked on workforce readiness and preparedness and training, because I think we all face the same issues in terms of scaling our models. We need to really, I think, build a new clinical consciousness around what it means to practice in this world that I think is really foreign to most people who have grown up in our highly dysfunctional fee-for-service system.
Yeah, this is Gaurov. I agree with everything Sachin said, and I won't further expand on those. I do want to bring one other point up, which is, even if you look at, the title of our talk, innovations in primary care, Sachin mentioned, being radicals. Companies such as ours, CareMore, are still viewed as but are exceptions to the rule, because we are falling outside the mainstream fee-for-service milieu that's been created by this, lack of a better word, the medical industrial complex in this country. And I come from a hospital background. I have a lot of folks in the healthcare system background. And I asked this, and we get approached a lot by healthcare systems saying, hey, we'd like to do something cool with you guys. And a question I always ask them is, are you currently building a hospital, or have you recently built one? And I'd say 50% of the time the answer is yes. And I ask them, well, what approximately is the cost of your hospital that you're building? The answer usually is around $300 million, $400 million, depending on the size. So my question, I always say, for $300 million, and name a city, Cleveland, we could probably put up 100 ChenMeds across Cleveland if you sponsor us. And I'm just using that as an example. We're not talking to anybody in Cleveland. But if you really want to do something transformational, don't build the next hospital, and use that money to build access points across the city with underserved, overserved, medium-served populations, and you will significantly drive better health, better outcomes, and lower costs. As you can imagine, there's never any takers for that, because their business model is still fully dependent on fee-for-service medicine. So I think the biggest rate-limiting step is the fact that we are still in this duality, where hospital systems are still trying to figure out what the path forward is. And while they're thinking about that, they're still investing in fee-for-service medicine. Our business model is completely antithetical to that, right? We want to lower costs, we want to improve outcomes, we want to keep people outside of the hospital. And there is just a conflict that naturally occurs that only is resolved in a Venn diagram in plans such as Medicare Advantage, where there's a alignment of incentives, but those are few and far between still.
Well, I think that I wanted just to say, I absolutely agree with that issue around very different incentives. I always often think of the healthcare system, you have a foot in two different canoes and they're pulling in totally opposite directions. I just wanted to add that from a policymaker, if I put my policymaker hat on, I think one of the things, that you have to think about is, if I can paraphrase Spider-Man, with greater flexibility comes greater accountability. And I think there's a lot of reluctance to move towards these models that are much more flexible because we don't always have good accountability measures in place, or we aren't comfortable yet with the accountability measures. So, as I think about what you need in order to scale these models, you do need to think about the accountability. If you're asking organizations to take on risk and then deliver services that are needed by a patient or by a consumer, how will you measure that those services are being delivered? And from a consumer perspective, sort of what kind of accountability is there in the system? And I would argue from my advocacy perspective that consumers have a huge role to play in being part of that accountability mechanism.
Great. Thanks, all. As we think about some of the social needs and health disparities that all are important to be addressed here within the U.S., and you think about racial and ethnic disparities in health outcomes, how do these, in your opinions, provide these primary care models address and potentially reduce health disparities? What are your thoughts on that? So
maybe I'll take, this is obviously a very complex question, so I'll take a first pass at it. In our model at ChenMed, our clinics are by design built in underserved areas that are PCP desert. So when we look at a map of the country as to where we're going next, we look at, okay, what's the PCP ratio, what's the average wait time to see a PCP, and what's the access to physicians. What often happens in our neighborhoods is that the emergency room is the PCP. So while there's a lot of components to the social determinants and the needs of the average patient, one thing that we do believe we can impact is access. And access to us can be measured, in at least 3 ways. One is just the fact that we're putting a clinic in an area that is underserved, probably has been ignored by sort of the mainstream healthcare providers, and we put nice clinics there. The second thing we do is we make those clinics affordable, again, because of the structure of Medicare Advantage. Typically, it's a zero copay or very minimal copay, and if not, you can qualify for a financial waiver. And then finally, we provide transportation as well. So the end result of that is for neighborhoods that we enter, the one social determinant that we can help address is the ability and the access to get good primary care. I'm not saying that's one solution of many, but that's at least something we feel we can impact pretty well. It still doesn't solve for a very complicated problem.
This is Anne. I'm just going to add that I just think it has to be an explicit goal, right? And as part of that accountability mechanism, are you measuring disparities reduction? Is that a core goal of improving the system? And then I think on the other side, making sure to pay attention to unintended consequences. Are we inadvertently widening disparities or not? And in this case, you can't improve what you don't measure. So I think, setting some specific outcomes in this area would be really important.
Got it.
Yeah, I think one of the biggest challenges in this space, is we're not actually collecting racial and ethnic data. Last time I checked on this, CMS doesn't necessarily want us to do that as we enroll members for all kinds of good reasons. But I think it actually gets in the way of us documenting, the differential impact of these models on communities who need them. And so I think there is a policy opportunity there that we need to explore.
Got it. And speaking of some of the ways in which you address it and some of the tactics that you employ, one of the questions that came in from the webinar audience was about in-home visits and telemedicine. So specific to Gaurov and Sachin, do your models use those two approaches?
Sachin, Yeah.
Yeah, sure. So CareMore operates, an ISNP, which is an institutional special needs plan. So we have a special plan, special model of care, really, where we're taking care of home-based or institution-bound patients who have 3 or more activity of daily living impairments. So we have a long history of doing that, but we're increasingly pushing more care into the home. We have a new primary care model that starts with the home first that we launched in Connecticut in partnership with Jill Hummel, and then we've also got I think we're now in the process of partnering more closely with our sister company Aspire, which is a home-based palliative care provider, the largest home-based palliative care medical group in the country. And so we certainly believe that the home is going to be an important and growing nexus of care. I do want to put 2 cautionary notes out there. One is that many patients don't want clinical staff coming into their home. That is an important patient preference point that gets forgotten, I think, in the dialogue around moving care to the home. And then the second thing is that, it's a great model of care for patients who really need it, but it's highly inefficient for people who don't. And so, most home-based models see at most 6 to 7 patients a day, unless they're operating in highly dense urban environments where it's easy to get around. But the national average is around 6 or 7. And so, and if you contrast that with what a clinician could see in a clinic, which is 15 to 20 to 25, it creates real access issues. And when you think about that in terms of a national primary care shortage, I think we have to just be very careful as we balance, matching these clinical models to different populations.
Yeah, I think CareMore has done a lot of great work in this arena, and in many ways we're still in infancy around this. I think primarily around the fact that we're still a very hands-on model rather than providing the same services in the home. That being said, personally, I feel like this is the future with some of the challenges that Sachin mentioned. The other thing that I think that we're very interested in is the hospital at home concept. I think that 5 years from now, a decade from now, that's going to be routine. It's still in its infancy, maybe even in its embryonic stage. So as we look at these models, I think the ability to actually provide very complex care in the home environment is going to become very mainstream.
Great. And Anne, anything to add to that before we close?
No, I think, I would just say that for a subset of a population, particularly people who have functional limitations, and specifically physical disability, I think home visiting can be a really important adjunct. We've actually done some educational videos for providers on this particular point, and it can really be very, very helpful for making the system more accessible for that specific population.
Great. Great way to end. I want to thank the experts on the panel today for all of your insights, and also thanks to everybody who joined today. As I mentioned, almost 400 at the highest point during this webinar. And please take a look at PCPCC.org website for additional resources, and stay tuned for the next webinar. Mark your calendars for May 15th, 3 p.m. to 4 p.m. Eastern Time. With that, have a great day, everybody, and thanks again.